Hi, this is the second part of the lecture about female reproductive system, and I will talk about the cervix, especially concentrating on cervical intraepithelial neoplasia or CIN, and also cervical carcinoma. So cervical intraepithelial neoplasia has undergone different classification systems. The oldest will be dysplasia, which is mild, moderate, severe, or carcinoma in situ. And this classification is followed by CIN 1, 2, and 3. And the most recent will be low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion, or in short known as low cell and high cell. So low cell includes previously classified CIN 1, and H cell is previously classified as CIN 2 and 3. Why is there a change in the classification? This is because although the classification used to be 3-tiered, but the decision for treatment has always been 2-tiered, which is whether it's observation or surgical. So for low cell, there will be no significant disruption or alteration to the host cell cycle, and mostly they regress spontaneously, and a small percentage progress to high cell, and more than 80% are associated with high oncogenic risk HPV. So low cell has usually we'll put these patients on observation first. And for high cell, these patients have lesions that are progressively deregulated by HPV, and it has an increased cell proliferation with decreased or arrested epithelial maturation, 100% associated with high oncogenic risk HPV, and it has a 10% risk of progress to carcinoma. Histologically, the grading of the squamous intraepithelial lesion is based on the immature cell layer expansion from its normal basal location. So low cell is confined to lower 1/3 of the epithelium, while high cell expand to 2/3 of epithelial thickness to full thickness, and it may have atypical mitosis. So this is a nice chart to describe the progression of cervical intraepithelial neoplasia. So this is normal squamous cells, and this is to show you mild dysplasia or CIN 1, or known as low cell now. It's located to the lower 1/3, and progressively, if it begins to come to high cell or previously CIN 2, it will be involving more than 2/3, especially in the severe part. And if it's carcinoma in situ, the most severe part of the high cell, it will involve full thickness of the epithelium. Histologically, you will see a nuclear atypia, which is characterized by nuclear enlargement, hyperchromasia, presence of coarse chromatin granules, and variation of nuclear size and shapes. And you will see loss of polarity. That means you don't really see the distinguishing feature between the basal cells and the rest of the epithelial cells anymore. And these changes can be accompanied by koilocytic atypia, which is these irregular hyperchromatic cells, hyperchromatic nuclei surrounded by cytoplasmic halos. So this is to show you the normal squamo-columnar junction. This is the columnar epithelium, and this is the squamous epithelium. And when there is low cell, there's atypia involving the basal layer or lower 1/3 of the epithelium, and some parts of the epithelium may exhibit koilocytic atypia, as you see here, surrounded by the cytoplasmic halo. And this is to show the difference between low cell and high cell. So high cell will show the atypia involving more than 2/3, and in this picture it involves almost all full thickness of the epithelium. Right. So for cervical carcinoma, the peak incidence is about 45 years old, and it's all associated with high oncogenic risk HPV. Basically, you can classify the types into four, which is the most common will be squamous cell carcinoma. Second will be adenocarcinoma, which arises from precursor lesion adenocarcinoma in situ, or AIS. Next is adenosquamous carcinoma, and fourth will be neuroendocrine carcinoma. So for adenocarcinoma, adenosquamous carcinoma, and neuroendocrine carcinoma, they usually present as advanced diseases because Pap smear is less effective in these lesions. Pap smear is more effective to detect squamous cell carcinoma and its precursor, high cell and low cell. Pap smear has definitely reduced the incidence of cervical carcinoma, especially in countries with established routine screening. Morphologically, you will see cross-fungating exophytic lesions or infiltrative lesions, and it can be advanced on presentation. It can extend by direct spread to the adjacent tissues, for example, paracervical tissue, urinary bladder, ureter, rectum, and vagina. You can also see some lymph node involvement or distant metastasis. And it's important for me to stress to you that you have to know the risk factors for developing cervical carcinoma. And the most important risk factor is sexual activity and multiple parity, and so cigarette smoking and so on. And you probably should read up on the risk factors. For squamous cell carcinoma, they present histologically as nests and tongues of malignant squamous epithelium, which can be keratinizing or non-keratinizing and invades the underlying stroma. So if you see the epithelium here, and the malignant cells has already invaded into the underlying stroma, and it's surrounded by the desmoplastic stroma. And squamous cell carcinoma may form keratin pearls and intercellular bridges. And this is high power. You will see the squamous cells have keratinization in them, which is pinkish in color. And if you go even higher power, you may see intercellular bridges, and this is the desmoplastic response. And sometimes you can see necrosis within the tumor. Adenocarcinoma of the cervix, you will see malignant endocervical cells with large hyperchromatic nuclei, and that is reduced mucin compared to the normal endocervical cells, and this results in the dark appearance of the glands. This is to show you the difference between adenocarcinoma in situ of cervix and normal and cervical glands. So the normal cervical glands have basally located nuclei and apical mucin, so there is no loss of polarity here. Meanwhile, for adenocarcinoma in situ of the cervix, there is relatively no apical mucin seen, and the basally located nuclei is now expanded and elongated and become hyperchromatic. But for adenocarcinoma in situ, it has not invaded the basement membrane yet. Adenosquamous carcinoma is self-explanatory. It is mixed glandular carcinoma and also malignant squamous epithelium. So you have both of these components here: squamous epithelium, malignant squamous epithelium, and malignant glandular epithelium. For neuroendocrine carcinoma, it is composed of relatively small blue cells with scanty cytoplasm, ill-defined cell borders, and finally granular nuclear chromatin, or in some textbooks will refer as salt and pepper pattern, and there will be loss or inconspicuous nucleoli, so as you can see here, and it's also associated with crush artifact and nuclear molding. Okay, so that's it for the lecture for cervical pathology. So the next part will be pathology of the uterus. Thank you.